Well, thanks everybody for coming. I'm really excited to introduce this panel. It's about finding the right data during COVID-19. I mean, what could be more timely? I think as journalists, it really behooves us to be able to look at this outbreak the way that epidemiologists do, and be able to sort of read what's going on and who's affected and why they're affected and what, the latest studies and vaccines mean based on data. So without speaking more myself, let me just introduce my panelists. I have Jennifer Nuzzo, who is a senior scholar at Johns Hopkins Center for Health Security. There's Nicole Basta, who is an epidemiologist and biostatistician at McGill University, and Kevin Barnett, director of the Center to Advance Community Health and Equity at the Public Health Institute. So thanks so much to my panelists for taking time to speak with us. And I've got it so that Jennifer is going to talk a little bit about what sort of, what can we read in the data about transmission. Nicole's going to speak about vaccines, and Kevin will speak about equity and disparity and how we can understand those issues better with numbers. So to kick it off, I guess, Jennifer, I'd love you to start.
Great. Thank you so much, Amy. And thanks to the organizers for including me. Really appreciate the ability to talk about this topic. The news is all COVID these days with good reason. Across the country, we're seeing a tremendous growth in the total case numbers. It's really surging in nearly every state. We're also deeply worried about the rise in hospitalizations. This is, I think, turning the conversation to whether we can stay on the same track or whether states may have to shut down again. I know I got a lot of questions from journalists about that particular topic over the weekend, and so I just wanted to maybe reflect a little bit on what I look at when asked those questions, because I think it's important for us to look at that now, but also to track going forward, even if in the coming weeks when we continue to keep tabs on what's going on. So we know a number of states have begun implementing the process of restrictions once again. Maryland, where I live, has tightened occupancy caps at restaurants. New York's done the same. And over the weekend, you probably heard that Michigan announced much more aggressive closures, for which they've largely gotten praise from public health experts, in particular because they're taking a fairly nuanced approach. Closing the highest risk venues, but also trying to keep elementary schools open. But the question is, what about for other states? Will they need to shut down? And when I'm asked that question, I look back at the metrics that states should have been using in the spring and the early summer in terms of making decisions about whether it was time to reopen. There were three kind of main metric areas that they were looking at. The first one was on cases. And, to decide whether to reopen, they should have seen that case numbers were not increasing, that hopefully they were stabilizing or better yet decreasing. The second metric that they should have been looking at was their healthcare capacity. And in the spring and the summer, there was a lot of conversation about ICU utilization, because that's really a place in the hospital where we most worry about limited resources. And then the third area is whether the state had enough resources to shift from a population-based restriction, which is what shutdowns are, to more of a case-based approach, where they're going after individual infections through testing, isolating anyone who tests positive, contact tracing, trying to find the people who may have been exposed to a positive case, and then quarantining those individuals until we know for sure that they aren't contagious. So those case-based interventions are fairly resource-intensive, and so ideally states would have waited until they had those resources in place, personnel to do that work, the appropriate testing resources, and that would have created the best conditions for reopening. Unfortunately, we know that many states did not rely on those criteria in making their reopening decisions, and really there was a lot of political and economic pressures, so they reopened nonetheless. But the reason why I'm bringing up now is that very much what we need to be looking at is those metrics again, but in reverse. And so, our first assessment should be how are we doing with respect to those three metrics. And unfortunately, if we see bad trends that may signal the need to shut down, or I think I like this metaphor that's out there about sort of like tightening the faucet. Maybe not a complete, total kind of statewide lockdown, but finding areas within states where we can tighten up restrictions to try to put us back on a better path. And so where we are now with respect to those three metrics is I think we largely, in most places, have three strikes, right? So we're seeing increasing case numbers, we're seeing increasing hospitalizations that are likely going to result, at least some portion of them, in ICU utilization. And we're also seeing case numbers potentially surging past the point where states can maintain case-based interventions. There was a news story about a month ago that North Dakota basically announced that it was no longer going to be really doing contact tracing because they couldn't keep up, and they basically told their population that they would have to conduct their own contact tracing should they test positive for COVID. I know for certain that a number of states are probably in that exact same spot, even if they haven't announced it publicly like North Dakota did. So those, I think, are three worrisome signs. But going forward, if we only look at those three areas, they're clearly very important, but they also are a bit of a slight lag. There's a slight lag in each of those areas where it may be important to kind of shift a little bit in the data in order to see potential trends coming. Now, we may be at a point where we have already seen bad things in our trends, but there are still some parts of the country where things aren't quite as bad, and perhaps looking at some of the earlier warning metrics may be instructive. So, and the reason for this is, I've sketched out here on the slide, where those three metrics are. The number of cases, number of hospital beds that are used or available, and the number of deaths is also an important indicator that people look at. But you can see where those metrics are on the timeline. They're a bit later, and they sort of apply to a smaller portion of the population. What I'm proposing is that we try to shift left a little bit, try to find metrics that occur earlier and that affect larger numbers of the population. I'll go over a few of those right now. So I'm going to talk about metrics in three areas: testing, contact tracing, and hospital admissions, which is similar to what we're looking at right now, but if we only look at things like ICU utilization, that might be a little bit late for our interests here. So these three areas that I'm going to go through separately are a bit earlier in their indication of potentially increasing disease spread, and perhaps if we kind of shift left in the timeline, and these metrics also potentially apply to larger portions of the population, they might give us a better signal a little bit earlier that things are headed in the wrong direction. So the first one that I'm going to talk about is testing. Now, testing is in the news. It's been continued to be in the news since the spring. The metric that I look at most closely when trying to assess whether we're doing enough testing is on test positivity. And basically that means the percentage of people who are tested that come back positive, or the percentage of tests that are done that come back positive. They're both ways of calculating positivity. Ideally, you want that percentage to be low. The WHO has sort of set a 5% as a benchmark, but that's just a benchmark. It's not a magic number. The thing is, you want to look at that and see what those trends are. If positivity starts ticking up, that should be sounding the alarm bells that something is happening and that we need to go out and do more testing to figure it out. Because really what positivity is trying to do, it's not a measure of how much of the population is infected. It is a measure of if we're doing enough testing. And if that percentage starts going up, what that says is that we're trying to ask the question, are we casting a wide enough net to find the infections that may be out there? If that percentage is going up, what that starts to tell us is that we're likely starting to miss more and more infections. We're not counting those people who are infected as cases because they haven't been tested, and they may not even know it, and they could be going and spreading it unknowingly. So as positivity goes up, that really starts saying, regardless of what the percentage is, even if it's low, if the number is ticking up, that starts to worry me that we are headed in the wrong direction, and we need to figure out why, and the response needs to be to go out and do more testing to try to figure out where the pockets of infection are that we're missing. Okay, the next metric that we look at is on contact tracing. Now, this is one of those things, and I kind of implore journalists on this front, that is poorly tracked. States will often tell you what percentage of cases they conducted contact tracing on. They'll tell you maybe what percentage of the contacts they were able to reach. Those are not irrelevant metrics, but they also don't tell you how well contact tracing is working. What we really want to know is a metric that's not typically reported publicly, but should very much be asked of states that are talking about how they're responding to COVID, and that is what percentage of new cases are coming off of known contact lists. Ideally, that would be a high percentage as we go forward, and if we had enough contact tracing, probably right now, given where their case numbers are, I bet it's very, very low. And if that's the case, then what that's telling us is that those case-based interventions are not doing what they're supposed to be doing, that we are missing opportunities to interrupt transmission. And when we do that, that means we have not gotten a handle on it through those targeted interventions, and that puts us on a path, unfortunately, towards broader restrictions. So I very much look at that and ask about that as much as we can. And again, it's not just about reaching people on the phone. It's about finding them, telling them that they may have been exposed, making sure they're sitting at home so that if they do become positive on a COVID test, they're already at home and not out and exposing people. And so then when they become positive, they would be a new case, but hopefully they're already sitting at home under quarantine. And I can tell you probably where we are as a country right now is that that is just largely not happening, and it hasn't been happening, and that's possibly why we're in the situation that we're in right now. So just one more thing, hospitalization. So we talked about this a lot. This is clearly something that's on the rise across the country. There's a reason why people are worried about this, because as you can see where we are headed to the right of where that arrow is, the top right-hand corner, is that when people start becoming admitted, there will be likely in 3 to 4 weeks from now an uptick in deaths. Before that, admitted to the ICU. Those are the things that are really, really devastating. We're already starting to see it in a number of places. I think hospitals are overwhelmed now, even without huge surges of critically ill patients, but certainly huge surges of critically ill patients that require ICU care is incredibly difficult because that's one of the most limiting resources that we have. I mean, the personnel to be able to provide that level of care. At Johns Hopkins, we have a national map of cases with respect to counties, and one of the things that you can see on that map is what level of just healthcare resources each county has. And it's really startling when you click on counties where you see high percentages of deaths, and then you look at what their, say, critical care bed capacity is. And some places, they have 0 ICU beds or 4 ICU beds. That means that those people in those counties have to travel far, potentially, to get care. So this is something that's really worrisome. But the kind of earlier indicator that we are headed towards those really dangerous outcomes is looking at the number of people presenting at hospitals, but also the number of people who are ultimately admitted to hospitals. We're headed into the fall. This is going to also increase, and so this is why you're hearing epidemiologists and others stressing how worried they are about the situation that we're in. So the last thing that I just wanted to show you, we are tracking a bunch of things at Hopkins. We're obviously tracking cases. You've probably seen the global map. We also have a U.S. map, as I said, that looks at cases at the county level and what the kind of baseline demographics and healthcare resources are in each of the counties. But we are also tracking testing and giving a national look at test positivity as well as a state-by-state look. And one area that we're also tracking, and it's relevant to these metrics in particular, is on policy. And I'm just showing here one of our states because I think it makes a particularly compelling example, Arizona. So as you remember, Arizona over the summer saw a huge jump in cases. In fact, in the 2-week period at the beginning of June, they saw a 150% increase in the number of cases. You can see that steep portion of the orange curve, that first bump on this graphic here. What you see to the left of that bump are a bunch of dotted green lines, and those dotted green lines are reopenings. And this pattern is typical, and we see this in a number of states where you see one or more, usually more, reopenings, and then about a month later, you see a steep orange line. And then usually a red dotted line kicks in, and that's a closure, and then you see it start to tick down. And in fact, Arizona implemented a number of restrictions. They implemented a statewide mask order. They also closed restaurants and bars. and it had an impact. In fact, by August, they saw a 75% decline in the number of cases. So it's interesting to see that. Over the summer, there was a court case that required that the state establish metrics for reopening, and by the beginning of October, all counties in Arizona had met those metrics. But you can see the curve is once again going up. And so these openings and closures, again, these can have impacts, but they're temporary. And part of the reason why they're temporary is that they need to be replaced with case-based interventions, the testing, tracing, isolation, contact tracing. And so that's why looking at all of these metrics can give us a sense on what part of the curve we're on. And in particular, the earlier metrics can kind of point to, hopefully, that when we're starting to tick up before maybe we even see it turning up in the case numbers. So on there, and looking forward to participating in the discussion.
Thanks, that was excellent, super interesting. Somebody asked, what should the hashtag be? I don't know the official hashtag. I used hashtag AHCJ2020. So how about that?
Great.
Well, great. How about, let's see, I'm not sure who we had decided is, I think, how's Nicole, would you like to talk about vaccines next? Is that correct?
Yes, that would be great. Thank you, Amy.
Okay.
All right, well, good morning, everyone. And thank you so much to the organizers for inviting me to present here today. As I'm sure you'll all be aware, there's a lot of COVID-19 vaccine news coming out these days. And as Amy mentioned, I'm an infectious disease epidemiologist, and specifically I'm a vaccine epidemiologist, which means that I try to understand how we can design and implement studies to figure out what the optimal vaccination strategies are. So taking the population-based approach to using vaccines to be sure that we can get the maximum benefit that we can from these really important tools. So today I'm going to talk a little bit about some of the work that we're doing tracking COVID-19 vaccine development and try to put some of it in context to hopefully give you an overview of the landscape of what's happening with COVID-19 vaccines. So COVID-19 vaccine development is really characterized by a couple of interesting characteristics over this past year. The first is the unprecedented speed. So you'll recall that just a year ago, we didn't even know about this virus. And so back in January, it was first sequenced. By March, our first phase 1 vaccine trial had begun. In July, the first phase 3 trial had begun. And then now in November, there are more than 50 vaccine candidates in trials. And the first phase 3 interim results were reported last week, and the second results were reported just today. This is really a timeline that we haven't seen before for any other previous vaccine development efforts. And with COVID-19 vaccine clinical trials, the timelines have really shifted. So in the past, historically, phase 1, phase 2, and phase 3 trials have progressed in sort of a linear fashion, increasing from a small sample size to a larger sample size to the thousands and tens of thousands of participants that contribute to the efficacy trials in phase 3. But of course, the urgency of COVID-19 indicates that we really need to start developing vaccines at pandemic speed. And this is quite a challenge. First of all, from phase 1 to approval, that often takes years, if not decades. And historic data has shown that about 80% of past vaccine candidates fail to complete all trial phases. So even those that enter phase 1, about 80% fail to make it onto review and approval. So this is really a massive challenge that we're facing. Fortunately, with COVID-19 vaccine clinical trials to date, we've seen a lot of improvement in the timelines for evaluating these vaccines. So maintaining the same level of rigor in determining the immunogenicity, efficacy, and safety of the vaccines throughout the trials, but overlapping some of the trial phases, beginning one phase before the complete results of the previous phase is available, and infusing a great deal of resources and a great deal of funding in order to make sure that these trials can progress as rapidly as possible, so we can really understand more about how well these vaccines protect as soon as possible. And the other thing that's characterized COVID-19 vaccine development is really the global landscape. So this map here just shows the location of the development of more than 200 COVID-19 vaccine candidates that are both in preclinical development and in clinical trials. And as you can see, there's a number of different candidates coming from every region of the world. And on top of that, trials are happening in more than 30 countries worldwide as well. So So it's with this global landscape in mind that we started thinking about tracking COVID-19 vaccine development. And our efforts were really motivated by the desire to increase knowledge and transparency about COVID-19 vaccine evaluation for the public. So early in the pandemic, I was constantly being asked when a vaccine will be available, but also questions about what the process was going to be to ensure that these vaccines were safe and effective. There was a lot of concern that corners might be cut in evaluating vaccines. So having the opportunity to increase transparency at a time when people are paying more attention than ever to vaccine evaluation was really a great opportunity. We also felt that it was important to focus on the progress that we're making with COVID-19 vaccines globally and to set realistic expectations for when vaccines might be available. And we felt that this effort would really build confidence in vaccines and trust in the process from the very beginning, because that public health communications piece regarding vaccines really needs to start from the very beginning of development rather than waiting until a vaccine is available. So this is a tool that my team has developed. It's a COVID-19 vaccine tracker. It's available at covid19.trackvaccines.org or just www.trackvaccines.org. And it really has two components. The first is a map, which is tracking the highest phase of clinical trials that are taking place in a given country. This has been a really popular feature as we have quite a global audience that is using the site, and they're really interested in what clinical trials and what vaccines are being tested in their jurisdiction. In addition, we track how many vaccines overall are in clinical trials, so phase 1, phase 2, or phase 3 testing, how many trials there are, and then how many countries are participating in at least one trial. So as you can see, right now we have more than 50 vaccines, more than 120 trials, and more than 30 countries are conducting trials. The way the site works is that we've tried to layer it so that people that just want a quick overview of what's happening with COVID-19 vaccines can look at our tracker timeline and see how many vaccines are in phase 1, phase 2, or phase 3 testing. So for instance, there's 11 vaccines right now that are in phase 3 testing. And each vaccine then has a vaccine card. So that's these cards here on the right. Each card is color-coded based on the type of vaccine technology that's being used to develop the vaccine. The developer, the primary developer is listed, the name of the vaccine, and then a summary of how many trials are happening in how many countries. And we've done that for each of the different vaccines so that we can kind of keep track of comparing what the different technology is that's being used. Many of you will be aware that so many different platforms are being used to create COVID-19 vaccines, and many of these have not been used before to develop vaccines. So we thought it was valuable for us to learn from results that we're seeing for one vaccine and compare that to other vaccines that are using the same approach and the same platforms. So we have these same vaccine cards for vaccines in phase 2 and phase 1 of testing. And as I mentioned, the site is layered. So if you click on any of these cards, it will bring you to a detailed card about each vaccine. And these detailed cards tell you a little bit more about each of the trials that are in each of the phases. And then there are trial cards down here at the bottom that tell you where the trials are happening, how many participants are enrolled, and then you can link out to the official trial registry record if you want to find more details about things like what the comparison groups are or what the age groups are that are involved in these trials. So with this effort, we're really trying to consolidate information about the COVID-19 vaccine landscape into something that's easily accessible. We update the website weekly. New features are added often, as well as new data. So we've been lately collecting data about the comparators that are used in each vaccine trial, the number of doses, the route of administration, factors that are going to be really important for the eventual rollout of COVID-19 vaccines. And we're aiming for this to be a resource for not only the general public, but researchers have found it to be really valuable, as well as journalists. And we've garnered a global audience so far with a lot of interest from people around the world who don't quite have as much access to information about what's happening in real time with regard to vaccine evaluation in our country. So please take a look at the site and feel free to provide feedback. We have a feedback form, and we also have the opportunity to ask questions on the site. And for the last comment, I just wanted to highlight a couple of the key considerations that I look at when I'm considering vaccine clinical trials. So as I mentioned, I've worked on vaccines for more than 10 years now, and most of the time what we're learning about vaccines really helps us if we put it into context of what we've learned about previous vaccines. So with the COVID-19 vaccine clinical trials, most of what I do when I'm trying to evaluate new evidence that's coming out or new information is try to figure out how that fits into what we've learned about other vaccines and what insight that can give us about whether this is something unusual or whether this is something that we've seen before. So with COVID-19 vaccine clinical trial results, especially the phase 3 results that are coming out, I think it's really important to consider whether we're seeing the interim results or the full results. In addition, no single number in epidemiology, I think, ever tells the entire story. I think Jen did a really great job of showing us that with some of the metrics for outbreaks and transmission. So whenever I'm presented with something like the reported vaccine efficacy, I always think about what the sample size was, how many participants there were, who the participants were, what the age groups were of those who were eligible for the trial, whether there were other characteristics of the individuals that were eligible, because that helps us to really understand how generalizable those results are going to be and whether we've missed anything. Many of the vaccine clinical trials for COVID-19 are being tested in adults or older adults, but fewer are being tested in children. So that means that we'll really need additional evidence and additional studies, likely from phase 4 studies, to figure out how well those vaccines work in those other age groups or in special populations, such as immunocompromised individuals. And then in terms of vaccine efficacy, you'll probably be aware that there's been a lot of focus on the endpoints that we're trying to evaluate in these trials. So vaccine efficacy can really be characterized based on a number of different endpoints, whether the vaccine reduces the risk of infection itself, whether it reduces the risk of infection-confirmed illness, severe illness, hospitalizations. There's a number of different ways that we can characterize how the vaccine is reducing risk. And it's really important to know when you're presented with an estimate of vaccine efficacy, what the endpoint was, both the primary endpoint and secondary endpoints. And then as we're seeing some of these interim results, we really need to look ahead to the full results because there are many questions about the duration of the follow-up of these trials and how that will indicate what the duration of protection that these vaccines might afford. In addition to efficacy, of course, adverse events reporting is very, very important and something that we're getting less detailed data about in these interim reports. It's something that we'll want to keep an eye on when the full results are released. And with adverse events reporting, I think it's very similar to what I just mentioned about trying to characterize the results in parallel with previous vaccines that we're already using. So for instance, if a vaccine has something like, 60% of individuals who receive the vaccine have a mild adverse event, something like injection site pain. How does that compare to something like the tetanus vaccine, where that's also a very high proportion of people that experience such an adverse event? Just trying to put it all into context. Otherwise, it's very difficult to interpret any of these single numbers on their own. And this slide, I was just sharing a little bit about vaccine efficacy. So for those of us who work in this area, we do have specific estimates for vaccine efficacy based on the different endpoints. And these are actually really important for determining how to optimally use vaccines in the future. So many of the phase 3 trials are typically reporting what we call the VESP, which is just the vaccine efficacy against infection-confirmed symptomatic disease, which is a very important metric that tells us how well the vaccine protects against the person actually experiencing the symptoms of the disease and having the illness. But for instance, understanding how well the vaccine protects against infection as well can help us figure out the degree of herd immunity that we might need to achieve and how well the vaccine will prevent transmission as well as symptomatic disease. So I think the final point I just want to make is that developing safe and effective COVID-19 vaccines is really only the first step. Once we have vaccines available, we really have to start shifting our focus to figuring out how to design effective and equitable vaccination programs. Many countries are putting out priority vaccination plans, and those timelines and those priorities are going to be very, very important. But we're going to have a lot of decisions that need to be made, especially once many candidates are available on the market that have different characteristics, different requirements, that are targeted at different age groups and have different levels of efficacy. So I think tracking COVID-19 vaccines is really just the beginning. So I've put here the timeline of vaccine development through clinical trials. And then I've just added the development of vaccination programs and kind of all of the different stages in the process that we need to consider and the really extensive efforts that are going to be needed to really figure out how best to implement these vaccines once they become available. So with that, I think vaccines have the potential to be one of the most powerful tools of pandemic control that we have. And tracking COVID-19 vaccine development is just one of the first steps to setting the foundation to understand the global landscape and inform COVID-19 vaccination programs. But of course, in the interim, we really need to set realistic timelines because there's a lot of public health interventions that can be very effective in the interim as we wait for vaccines to become available, and that will continue to be important even after vaccines become available. So with that, I'll just thank my team who's been working on the COVID-19 vaccine tracker, and thank you all for listening. I'm looking forward to the discussion.
Great. Well, thank you so much. And in answer to one of the questions that came up, there will be links to the breakout room after this session. So you'll be able to see those for everybody in the audience who's interested. And we'll just move right ahead, and then I'll go back and ask all the panelists different questions. Kevin, you're up next. Let's talk about COVID disparities, but kind of deeper health inequities. I know you're interested in all of those. And what can journalists use to be able to put a little bit of numbers onto all of those disparities that we see?
Thank you, Amy, and thank you to my colleagues for sharing your expertise as it relates to a lot of the details of the pandemic, vaccines, testing, et cetera. As Amy indicated, I'm going to provide a little bit of a larger frame for how we are looking at the outtake associated with the pandemic and what are some of the ways in which our healthcare journalists can help better understand and help us as society come to terms with what we need to do going forward. It is clear that coming to terms is a major frame for this pandemic for our society, and by that I mean coming to terms with the profound inequities in our society and the manifestations of those inequities with a much higher rate and acuity and mortality rate in so many of our communities. We know, of course, that older adults are more significantly impacted by this, but we also know that our communities of color, our low-income communities, particularly in our urban areas, have been impacted profoundly by this pandemic. We know because we are gradually learning that where you live makes a fundamental difference in your overall health status. We have people that struggle with poor living conditions, close proximity, exposure to lead, cockroaches, dust mites, and an array of factors that contribute to poor health. And layered over that, the day-to-day stress of living without a livable wage, without support for caring for our children. And in the context of the pandemic, we know that so many of our communities, so many of our workers that are required to get out in public, whether they're a bus driver, or drive a train, or deliver packages, are those that are much more exposed to this pandemic and struggle with how to avoid contracting this disease. This dynamic is paralleled in our healthcare institutions. That is the inequities. We have many of our hospitals in urban areas that are by location happen to have a much higher number of individuals coming into their emergency rooms with challenges because of limited access to services, and others that have a much better payer mix, many fewer low-income people coming into their emergency rooms, and in that context, we see that a lot of these safety net hospitals are negatively impacted by both the financial challenges associated with this, as well as the need to care for a large number of individuals with high acuity. How do we address this as a society? this is even before we were confronted with a pandemic, the recognition by the healthcare arena is that we had to begin to think more proactively about addressing the drivers of poor health, what we commonly call the social determinants of health. And this pandemic has brought this issue into sharp focus, just at a time when our healthcare organizations are assuming increasing financial risk for keeping people healthy and out of their institutions. This pandemic has driven home just how negatively they can be impacted by living in a fee-for-service system. While our health insurers have done quite well, particularly our commercial insurers during this time, our hospitals, many, if not most of which, have been financially devastated. And now this new surge, again, just at a time when many hospitals were beginning to open up to provide surgeries, elective surgeries again, are now having to shut down those operations, and are pressed by having ICU staff and personnel being overburdened, burned out, and looking at ways in which to supplement those staff with others. So this mirroring of inequities in our communities and in the healthcare arena is presenting us with a real fundamental challenge as a society. And the ways in which we understand and report on this is important. One of the ways in which we have worked in our centers at helping to drive home in cities and communities around the country these inequities is using a metric that are called prevention quality indicators. This is a set of diagnoses articulated by the Agency for Healthcare Research and Quality of diagnoses for mostly chronic diseases that an emergency room visit is for one of these conditions, one of these diagnoses, is clearly an indication that these individuals have poor access to timely primary care and preventive services. When you geocode these diagnoses rates, you see concentrations at the zip code and particularly at the census tract level, that these diagnoses are 2, 3, 4, and 5 times as high in these communities as in other communities. So beginning to overlay many of the socioeconomic data with utilization data for these PQIs. And if you look at the parallel data related to the COVID outbreaks and the diagnoses in these same communities, you'll see that it's the same dynamic, the same rates are reflected with those communities as well. So it's just important that we give very close attention to and focus to how we address the immediate pandemic, but it really challenges us to step back and say, what are we doing more broadly to address these inequities in our society that drive much higher rates, much higher mortality rates for people who are already impacted in our society. I will turn it back over.
Well, thank you so much. I think that's a point I think about a lot. What are we going to do once we know these health inequities? What do we do next? So let's see. To open it up to questions, I think I'm not surprised to see a ton of questions about vaccines, seeing as I think a lot of people woke up this morning to see the new data from Moderna, or at least the new reports of what the data is from the new Moderna vaccine. So maybe I ought to just jump in right there. Let's see, I think some of the questions immediately were about side effects. And they were sort of like, they're all kind of lumped together, a few different questions. One is, what's the magic number for when there's really been enough people vaccinated that we can see rare side effects? And do we know, is there other vaccines that have long-term side effects that maybe won't be picked up immediately? So what's sort of your response to that? And I think that gets to the sort of safety concerns that people have.
Yeah, these are really important questions. Thank you, Amy, for summarizing those. I think what we've seen so far from both the Pfizer and the Moderna press releases is that we're getting very little data about the potential adverse events. Both the mild and the severe potential adverse events haven't really been reported in these interim results. But the thing that I think that is most important is to recognize that with a phase 3 clinical trial of tens of thousands of people, 30,000 individuals, that is a standard size for a phase 3 trial that will give us some indication of what the initial short-term and less rare side effects might be. So that will be important evidence and important information that we need to know in order to determine whether these vaccines should be licensed and whether they should be rolled out. But always with vaccine development, we conduct post-licensure surveillance for adverse events. So in the US, the Vaccine Adverse Events Reporting System and the Vaccine Safety Data Network both conduct safety evaluation for vaccines that are used in the population. And I know for COVID-19, even additional systems are being discussed in order to put those in place so that once these vaccines are rolled out in the highest priority groups, we can continue to monitor them. Of course, there's always the potential that in the population, when millions of people are receiving doses, or in the case of COVID-19, even billions of people, there are likely to be rare side effects that we may not have anticipated or we may not have had any indication of during the clinical trials. And so that is something to keep in mind, that that phase 4 safety evaluation, the surveillance for safety events, is going to be another important component of data to determine whether these vaccines are safe.
Thanks a lot. And jumping around, one thing I was thinking about when I was looking at Jennifer Nuzzo's slides, there's that contact tracing metric, which is interesting. Back when I, was talking to Dr. Nuzzo about Ebola stuff, we would look to see that number of how many people are on the contact tracing list. I've heard a lot of, like you mentioned, actually since the beginning of the outbreak in the U.S., I've heard states or counties saying there's just too many people or beyond the point of contact tracing. And I guess I was just sort of wondering, what's your sort of response to that? Is there like a threshold number, and are we looking at a whole state or a county, or when is that decision made, or is there points when it's not worth it anymore?
Yeah, so, I think we may very well be in that situation and probably have been for some time in many states. That said, I think we also have to recognize that although we talk about contact tracing as something that public health routinely does, we really haven't in this country been doing it much. Even for diseases like measles, for which it's commonly done, health departments have lacked resources to be able to do this and largely have not for quite some time. So that's kind of the dirty secret of American public health. So what it meant then was, once we recognized that contact tracing was going to be important for this disease, that health departments had to rapidly scale up. And this is not something that's easy to do. It's more of an art than a science. And sure, there was some money from Congress that allowed states to hire people and stand up information systems. But that doesn't necessarily produce the outcomes that you want. And so that's why I stress, rather than looking at like the number of people who have been reached by phone, which is really just telling you if you're like checking the boxes, we have to ask, is contact tracing working? And if it's working, we should be seeing that percentage of new cases coming off of known contact lists going up. We are not even tracking that in most states. A few states I saw on Twitter, but their numbers are unsurprisingly low. So I think we're not there. That said, even though what that means is that contact tracing is probably been outpaced by the spread of disease to act as the primary means to interrupt transmission, that again leaves us very little, aside from testing and isolation, that leaves little other option but restrictions, broad societal restrictions. But even in the context of broad societal restrictions, let's say we shut down restaurants and bars and, or take the Michigan model, for example, contact tracing is still important even when it's not complete. Doing detailed investigations of cases, figuring out where they've been, tracing their contacts, doing detailed analyses of transmission chains, even if it's just a fraction of the cases that are occurring, can be very helpful for helping us to better understand where people are getting infected. because the goal is not to do a statewide lockdown. I mean, that's a really damaging measure, and it's applied indiscriminately. It would be far better to understand with some level of precision what environments are truly riskiest for transmission and what can we do to prevent transmission in those environments. It may require shutting those environments down, or it may mean making those environments safer. But that's another role that contact tracing plays. And so, before we kind of throw the baby out with the bathwater, saying that we have been completely overwhelmed, there's just too many cases and we can't do it, I say that we should double down, but double down making sure that it's a much more nuanced investigation so that we can better understand what the risky spots for transmission are, so that we can more target our societal restrictions rather than letting it get to the point where we have no choice but to shut down the whole state.
Yeah. Do you have any ideas for like a more nuanced approach? Would it be something like, people who work in congregate settings or things like that, where we know that this is going to be a particularly fast-moving spread?
So yes, I mean, that's certainly the case. I mean, identifying places where a large number of cases are linked to is important. That said, what I hear from a lot of states right now is that they'll tell you the percentage of cases that have reported working outside the home, or the percentage of cases that have attended a family gathering. Now, it stands to reason if somebody is infected and they go to a family gathering, they're probably going to infect a lot of people, and that's how you'll get a large number of cases that have reported going to a family gathering. But what that statistic doesn't tell you is where that first case, the person who showed up at the family gathering infected, where he or she got it. And if we knew that, we could potentially, fix those environments so that we don't have people bringing it home to their family gatherings. It's really hard to stop family gatherings from a societal level. It's hard on a population to not be able to see their family. But if we can prevent people from showing up at a family gathering with an infection because we have made the places where out in the community where they're likely to have picked it up in the first place safer, or shut it down, whatever we need to do, then we will see those numbers drop. So I think we need to dig in more deeply on our case investigations and to do the detailed transmission chains to figure out, okay, well, if this person got it from this person, where did the first case that we think we have ultimately get it from? And other countries do this. I mean, you see the transmission chains that come out of Singapore and in South Korea. I mean, really elaborate analyses that tell you, the hot yoga class was the place where people got it, not necessarily the whole fitness center. And we should be doing more detailed analyses like that.
Great. Also, so Kevin Barnett, so you're at the Public Health Institute, and they've sort of introduced a couple of tools or measures. One is the California Health Equity Metric, and another one is the COVID Equity Metric. And I wonder if you could speak to those, because sometimes, I mean, as a writer, when I'm trying to, if I have a suspicion, I'm looking at, say the breakdown of zip codes or counties, and I have a suspicion this one particular area is a hotspot for COVID, but I want to figure out why, or what are the deeper inequities that might kind of lead to that. I was wondering, are those metrics that can help, help me tell my story as far as that goes? Maybe you could say a little bit more about what those are and what numbers go into them, or what data goes into them.
Well, I can't address them in detail. Would have to do that as a follow-up. But there's actually quite a rich spectrum of tools out there that are out there increasingly to provide that frame. And we know that the commonalities are seeing these higher concentrations in low-income communities, in communities where there are a greater number of older adults, and none of this is rocket science. I mean, I'll set aside the epidemiological expertise of my colleagues. That is critically important, but it's not a mystery how and why and where we have these high concentrations. What we are not doing enough of in these particular neighborhoods and places is enough testing and enough contact tracing to be able to both highlight and help address these issues in a proactive way. So I think there are a wealth of mapping tools out there. The visuals are critical to help drive home the message to the people. I think if we did more of that in the broader media, I think people would have a better understanding and perhaps more compliance with this. But I think what is this experience is highlighting for us are that there are health challenges in the very same neighborhoods where there were concentrations of health challenges before COVID. And how we come together to address those issues is critically important. Again, my expertise isn't in epidemiology. It is in the issue of equity and in the broader issue of how we address not just the symptoms of poor health, but the drivers of poor health. And there are a growing number of tools that help us get at that. The question is, do we have the will as a society? Are our healthcare journalists helping to drive the dialogue out of simply access to healthcare and out of simply access to testing and vaccines, and to a much more fundamental social justice issue for our society of whether or not we are going to do a better job of taking care of each other and preventing these health problems from emerging in the first place.
Great, thanks. I see that somebody who sent in another message, they said the University of Wisconsin Population Health Robert Woods Johnson County Health Rankings also has data on these health inequities. I think to your point, it's true, a lot of these numbers are out there, but I know as a writer, it helps to also have a place to see them so that you're not just saying, this exists, trust me on it.
Sure.
So that's
sure. One of the tools that we've used is the Vulnerable Populations Footprint tool developed by the Community Commons. And we developed that with them with support from the CDC a few years ago. And what that provides is a quick identification of where are hospitals as it relates to a variety of jurisdictional boundaries. And we basically picked two proxies for health, and that is the percentage of the population at the federal poverty line and high school non-completion rate. And when you map those at the census tract level, and then you overlay any number of geocoded data that you can get on utilization patterns, you see dramatic alignment between where there are concentrations of poverty and high school non-completion and these issues. And I guarantee you, if we overlaid, and we have overlaid the rate of COVID in those very same communities, and you'll see that it is much higher. In the urban settings, these are the same communities that we redlined 70 and 80 years ago. They're still the poorest communities. They're still the communities with the lowest level of social mobility. They're still the largest number of people that are working without a livable wage, that live in poor living conditions, concentrated living conditions. And all of those factors layered over with the toxic stress of, am I going to be able to pay rent? Is the car going to start? Who's going to pick up the kids? I just got called into my second job. That day-to-day toxic stress has a direct physiological impact upon people. It has a direct impact upon their immunological ability to fight off COVID. And those are just realities that those community members face. And layered over that for many of the older adults is a sense of fatalism, a sense that here's yet something else, and I'm not sure I'm going to survive it.
Thanks a lot. I guess kind of relating what you're talking about with the kind of transmission patterns that Jennifer Nuzzo was talking about. So, we've got all of these measures, what's the rate of, test positivity? Is there a way, are we being specific enough? Are we just looking at, is the county level enough, or should we become, should we be more specific than that? Like you were talking about census tracts.
Yes.
What do you think? Yeah, Jennifer, have you tried to push on that, or do you have any thoughts?
Yeah, I mean, we need much more specific data, and we need it as local as possible. There are just whole categories of data that we aren't tracking that we should be. So I spent a lot of time tracking testing on our Johns Hopkins Testing Insights initiative, and only a small number of states, a handful, release data with respect to testing disparities. So we can map testing per capita at a county level, but we can't map who gets tested. And so with known disparities in infections, racial and ethnic disparities, we should be also tracking that with respect to testing, and very few states track that. We also have this problem of lack of standardization that makes it hard to compare and see where there are real hotspots or real problems, within a state or even within a country. And one thing we've discovered since we got deep into the testing data is how every state, because we don't have national standards for data reporting, we have standards for case reporting that have been established, but not every state abides by it. So one difference is not all states report probable cases. And this is going to be increasingly important going forward, because if states start using the new rapid tests, the antigen tests, those are technically, if they're not followed up by a PCR test, considered a probable case. And so the question is, will we even be capturing those in our national surveillance numbers? That's one standardization problem. Another standardization problem is on testing. So I talked about tracking positivity and looking at it going forward. Just know that if you're trying to compare positivities in two different jurisdictions, you may not be comparing the same numbers, because different states, and sometimes it actually differs at a state and county level, calculate those numbers differently, report the data that go into their calculations differently. So we have so much work to do to improve the data that we are using to make these really high consequence decisions. I have to say, 11 months into a pandemic, to be at this place is really disappointing.
Yep.
Great.
Turn to the vaccine. Don't have to be optimistic. Don't end on that.
Yeah, I have it. Well, okay. Let me ask you one more, and then we'll hop to vaccines. So somebody, one of the people watching, asks, and I guess any of you can chime in, but maybe Jennifer News is the best person. But feel free to chip in, anyone else. But so reopenings in southern states corresponded with warm weather. And there's some people, there's all this stuff out there. Do we know anything about virus dynamics in humid weather? It could be that people are going inside for air conditioning, but also we have this thing with, restrictions or reopenings and things like that. Do you have any sense of what exactly drove it? You showed us a tracker. Does that get to that question?
I think there's a lot of factors, but all of those things that you brought up are why nearly everybody I know is deeply worried about the coming weeks. I mean, we have in the U.S. reached historic highs in terms of our case numbers. We are now in most states reaching historic highs in our hospitalizations. What we saw before this point was transmission in the context of summertime months, which allows people to spend more time outdoors, potentially do some of their socialization outdoors, and also where we're not competing with other respiratory viruses. So we know that the cooler, less humid months bring a rise in respiratory viruses. And while we don't fully understand seasonality in the context of this virus, it's reasonable to think that there may be some impact where we could see greater transmission. But also, we have less opportunities to distance and still see people. And then add to what we're also worried about is the fact that we are 11 months in and people are really tired. And even though new restrictions are going into place, restriction alone does not necessarily interrupt transmission. It's compliance with the restriction. And so if people are, deciding not to wear the mask and deciding to gather in, have house parties and other things, because the bars are closed, we could still see a fair amount of spread. So people are very, very worried about the fall for all of these reasons.
Thank you. So Nicole, I know I looked you up, and you've done some studies I've read about how education can alter, individuals' decisions about whether or not they want a vaccine. It could be, kind of education about how herd immunity works, herd immunity in terms of how many people are vaccinated, in a population. Do you have any sense about, right, when we do have some vaccines that look good, the next question is, how to convince people that they're safe, how to maybe inform people's decisions in ways that's very clear. That's going to be really hard with all of the crazy misinformation that's rolling around right now. So yeah, do you have any thoughts about how that education should be done, even down to both the words and also the presentation of it? Like, is it in a poster? Is it in a news broadcast?
Yeah, these are really important considerations, and trying to address trust in vaccines and vaccine hesitancy is something that really needs to happen at a much, much grander scale starting now. Because if we wait until vaccines are available and we wait until the critical time when people need to be getting vaccinated if they're eligible, it's really going to be too late, especially given the history that we've seen with vaccine hesitancy and with the typical uptake for something like flu vaccine every year is only about 50% of the population in the U.S. So some of our previous research has looked at trying to educate people about the community-wide benefits of vaccination. And we found that if you tell people who are not planning to get something like the flu vaccine that it not only benefits themselves, it actually benefits their entire communities, and they can contribute to keeping everyone safe and to reducing transmission, that helps to motivate people that weren't aware of those benefits before. It's something that we're hoping to apply to COVID-19 vaccines as well and try to determine whether and how effective this is. But I think that some of the notes that I'd like to make, though, about current reporting on COVID-19 vaccine hesitancy relates to the surveys that are going around about what proportion of people would take a COVID-19 vaccine. And I think we've all heard these we've heard these results where a certain proportion of people from a certain survey say that they won't take a COVID-19 vaccine if it becomes available. But I would argue that even that question is actually problematic. Asking someone whether or not they would take a COVID-19 vaccine when there is no licensed vaccine, they know nothing about the efficacy, the safety, the trade-offs in terms of the benefit that they might experience and the side effects that they might experience, really indicates that no one can answer that question in a valuable way. But sometimes reporting that a high proportion of people have answered in the negative that they wouldn't take a vaccine actually creates more concern and more mistrust, even among those people who thought they were confident about the vaccine. So a better question is to ask, would you take a safe and effective vaccine once it's gone through rigorous testing and becomes licensed and is available? Because that adds just a layer of specificity about the type of vaccines that we allow to be given to people, which are those that have been rigorously tested. In addition, I think it's really important to shift the focus to asking people why they would be hesitant about taking a vaccine. As I said before about a single number not capturing everything, the proportion of people that say they wouldn't take a vaccine really masks the concerns that they have. Our work on vaccine hesitancy has demonstrated that people have a lot of really important, critical, and thoughtful questions about vaccines. And often they're just looking for the right evidence and the right information that kind of quells a concern that they've heard. However, on top of that, a number of other studies have shown that by repeating misinformation, we often reinforce it or we introduce it to those who maybe had not even heard it before, and that it's really hard to kind of undo that impression even when you tell people what the correct information is. So it's really a very fine line in terms of figuring out what the public health communication strategies need to be, but there certainly needs to be a lot more investment in campaigns to provide the information and the education and the evidence that people are going to need, especially in communities that have a great lack of trust in healthcare institutions due to historical reasons. So I think this is really going to be the next greatest challenge for vaccine rollout.
Thanks. So I've got another question. This one I'll put to Kevin Barnett. So how do you do this? This is a good question. So in reporting kind of data on health inequities and who's affected and why, how do you also make sure that you're not stigmatizing a community in doing that? Because there is sort of a fine line between sort of othering people or stigmatizing people when you're trying to summarize who's affected by a disease.
It is an important consideration, and we go back to some of the early work in the 80s by John McKnight and others of the whole concept of identifying and measuring assets in communities, the social networks and the ways in which people support each other in many of these lower income communities. I think it's important to have that frame because those networks, those connections, those strengths our points of leverage for taking action, and making sure that we are identifying ways in which, as journalists, tapping into those networks that have come together despite the many challenges, and in fact, because of the many challenges that they face. It is certainly important not to stigmatize the communities themselves for the conditions that has been thrust upon them, and to focus rather on what we do. 501R of the Affordable Care Act requires all nonprofit hospitals to conduct community health needs assessments. And suffice to say, we have spent an immense amount of time and money conducting community health needs assessments and basically documenting problems, and have done very little to actually address those problems. Our work focuses much more on ways in which we use data, ways in which we challenge our hospitals and health systems to come together across competitive lines, and in fact across sector lines, to invest with, engage the community development community to invest in areas such as affordable housing, healthy food financing, job creation, and the like. So I think we could do much more, getting beyond simply the one of the critiques we've heard from many colleagues of public health community, which is certainly challenged by this pandemic, is the recognition that we have under-resourced profoundly our public health community, and that we need to direct much more time and attention beyond the quote-unquote audit function, and how they can help connect the dots, how they can work with these stakeholders to better address these issues in a more focused way. In the community benefit arena, in essence, how nonprofit hospitals fulfill their charitable obligations. Most programs are relatively poorly designed in terms of geography. They will say, we serve our entire service area, and less often is there an explicit geographic focus and alignment with others on a sufficient scale to actually move the needle. So I think we need to do far more to talk about what we do and how we leverage our assets, how we leverage the assets of our communities, because we've assessed these communities to death. And each time we go back and ask people what their health needs are, they get a little more cynical because nothing was done in the prior 3 years to address those challenges. So I think we can avoid stigmatizing by actually holding our institutions' feet to the fire, to be much more strategic and much more robust about how we target resources in these very communities.
So actually this kind of goes kind of to what you're already saying. Is another person, they ask, what kind of specific measures can we ask local leaders to do to address these inequities? Like, do you have any kind of specific places to start? And I have kind of something to add to that. Who exactly should be holding feet to the fire? I mean, are these public health departments, or are these health departments that should be doing it? Or is it, us, the people on Twitter or whatever? So who should be pushing for these sort of changes, and which ones would you say are kind of most tangible?
Well, the good news is there are a growing number of healthcare organizations that are taking action in this regard. In terms of holding people's feet to the fire, our orientation and our work, we are working now with the National League of Cities in 10 cities across the country, and a big focus isn't about wagging your finger at hospitals and health systems. Certainly in the current context, if anything, our hospitals justify some sympathy for what they're having to deal with. So the real question is how do we use the data that are available? I mentioned prevention quality indicators. I mentioned using a variety of different mapping tools to highlight where these inequities are concentrated. And then we can look at, hospitals are charged with developing implementation strategies identify where the opportunities for alignment and focus of those resources, again, at the sub-geographic level, at the census tract and zip code level. It's an immensely positive exercise as we have used these data. If we look at, again, the patterns of infection with COVID, as well as looking at diagnoses for preventable conditions, we see very clearly where and how our hospitals and health systems, that they can still compete for the commercially insured populations, but particularly for our Medicaid populations, where we have such a high rate of preventable ED and inpatient utilization, and much higher rates of COVID. It's pretty obvious that we can do much more by aligning our resources, by addressing not just the access to health services, but ways in which we work with municipalities to address the needs for neighborhood revitalization, for expanding the availability of affordable housing without displacing populations, for investing in grocery stores and healthy food corner stores that provide more immediate access to the kind of healthy food that people should be eating. This is a part of building the resilience that prepares us for the next pandemic, and there will be another pandemic. So how do we begin now strengthening our neighborhoods that are so significantly impacted by the current pandemic?
Thanks so much. So, Nicole, here's a vaccine question. Are the vaccines that are being designed, is it going to be important to keep an eye on which ones are going to be able to be adjusted if, different strains of coronavirus mutate over the years, or if there's if there's pockets of areas that have different strains? Or are we going to be seeing, something like, the flu vaccines that have to be made every year, things like that?
Yeah, this is an important consideration, though I think it's one where we largely don't have all the answers right now. When vaccines are being developed and when the specific targets are being decided for the technology that will be used to create vaccines, the idea is to try to strike a balance between picking a target that is going to remain stable so that you have the breadth of protection that you would like, geographically and across different variations and strains, and that you are also targeting some portion of the virus or the pathogen that's stable so that it doesn't change much over time. So I think that that has been the strategy that has been taken so far, with the focus on the spike protein, and it will really kind of remain to be seen in the years ahead whether we will see the need for booster doses, either due to evolution of the pathogen or due to waning immunity among vaccinees.
Great, thanks so much. Another question, with Thanksgiving around the corner, and then it's going to be the Christmas season. Jennifer, do you want to speak to, if families really are going to be getting together, what kind of harm reduction strategies can you suggest? And speaking of contact tracing, is there anything that health departments or people can do, to make that a reality?
Yeah, well, it's a really tough year to think about traveling to somewhere that's not your home, to see people that you haven't been recently in contact with, to go indoors and to share a meal where you're likely not wearing a mask while you're doing that. Those factors really add up to make it a higher risk proposition than many other things that you could be doing. That said, if it's something that you're going to do, it's all the same protective measures that we hope you take otherwise. Trying to maintain your physical distance, wear a mask as much as possible, try to be outside more than you're inside, and I think from a contact tracing perspective, keeping track of who you saw and for how long you saw it is potentially helpful, and recognizing that in going and getting together, you are placing your loved ones potentially at risk. Some people may think about getting tested prior to seeing loved ones, particularly if they're going to see higher risk, older adults or people with underlying health conditions. It's not a bad idea, but it's not fail-safe, because you could take it one day and be negative, and then the next day test positive. And but perhaps that is one measure. So just be mindful of that, particularly when it comes to your more vulnerable relatives, what potentially the stakes are. And, if you can avoid it, this is possibly the year to do that.
Another question on vaccines. For the tracker, Nicole, will you be keeping, once these start appearing or when they're being bought, are you going to keep track of distribution? Because most likely there'll be vaccines that are good for some populations or unaffordable for other populations. Will you be looking at this? And what about on a global scale?
Yeah, that's one of our goals. So the very next step for us for our tracker is to start aggregating the efficacy and safety data for any trials that report their full phase 3 results, so we can start getting a sense of how the vaccines compare to one another. And then once licensed, we really want to have a tool that can tell people in any jurisdiction they're in around the world, where can they go to get a vaccine? Are they eligible? So based on whatever priority groups are implemented in that location, are they eligible to get the vaccine, and then which vaccines are available and how are they being distributed in each particular country? That's a massive undertaking, so I can't guarantee that it'll be available very, very soon, but that is the direction that we want to go in, because as an epidemiologist and I work in applied public health, and a lot of what we try to do is reduce barriers to vaccination, and we don't want not knowing where to get a vaccine or whether you're eligible to be another barrier that's going to prevent people from getting vaccinated with COVID vaccines in high numbers. So that's the direction that we're going in. I should also note there are many other COVID-19 vaccine trackers out there, and all of them are tracking something slightly different. So on our site, we have a list of several of the links for other trackers, and I think that they would be valuable resources to take a look at as well, because some of them might have additional data or be tracking additional elements that might be valuable as we continue to see how the COVID-19 vaccine story unfolds.
Yeah, speaking of different trackers, and maybe I'll put this to all of you. Like you were saying, there's so many different trackers out there, and Jennifer Nuzo pointed to there's differences in, what data people are collecting or how they're collecting it. You just said just different things, and and there's all of these different trackers or tools. Is there any? Are you hoping, in maybe it's too late for this administration? I'm not sure. Is there any sort of push, maybe in the next administration, to have there be, some kind of alignment between different tools, or have there even be the official coronavirus dashboard for states or for the country that people could go to, like I can go to when I want to see what South Korea is doing? Is there any movement towards unification in that way that you know about?
So I have seen an improvement in the type of data that have become available, in part because of, I think, these non-governmental pushes to track data. So when we started tracking testing, for instance, and sort of established positivity as a metric, it wasn't really something that states themselves were calculating or even necessarily sharing the complete set of data that would allow for a full calculation. That has increased, and so I think there has been some progress. But at the end of the day, I believe, and maybe this reflects my bias as, previously a practitioner epidemiologist working for government, I do really think that this is something that needs to be led by the government, in part because they're making decisions about allocating resources and about setting policies and other things. I think outside groups like ours in academia, we have skills and abilities, particularly on the data analysis front, that can contribute. But if it's not owned or even adopted by governments, I just think it's a harder hill to link it to action. So, my colleagues and I at Johns Hopkins with our Coronavirus Research Center, we always say in an ideal world we wouldn't be doing what we're doing, that this would be something that the government would be doing for us. So anyway, I think there's interest there, but I will also say that I think the places that are best equipped to do this from a agency perspective, an expertise perspective, like the U.S. Centers for Disease Control, I think they need more resources and more, informatics capabilities in order to be able to do it. And so, I think with resources, they could certainly, be a powerhouse on these data, but they need help in order to get there.
Thanks a lot. I thought maybe I'd give you guys a chance. Do you have questions for one another at all?
I really appreciated hearing from everybody and learned a lot. I always love to hear from others, like what they're, like, say in a magic wand, like with respect to the work, something that they're working on, if they could just fix like one thing, like what would the one thing be that they'd fix? And maybe I'll give you time to think about it. I right now, my like low-hanging fruit that I want fixed are data standards, particularly around testing. And we've seen states use even our testing data for very high consequence decisions like determining interstate quarantine. And they're doing that on not apples to apples comparisons. So to me, that's like a low-hanging fruit that could enable the data that's already there to have more impact and utility. So my very modest magic wand in hand would be to fix that right now.
Yeah, thank you, Jennifer. That's a great question, and I think that we all had a really interesting complementary perspective to share on all this topic. So I also learned a lot. I think in terms of if I had a magic wand, the things that I would like to see improve quickly as soon as possible, not only data standards but also transparency in how decisions are being made. It's really difficult to know what additional data need to be collected when we don't already know what evidence is being used to make decisions, and that varies quite a lot, I think, across a lot of. And then the other thing that I would really love to see is the degree of resources in terms of funds that have gone into vaccines be put towards behavioral interventions and the kind of population-based efforts to ensure that the rollout and the success of these programs can be to the highest degree possible. I think that's the aspect of epidemiology and public health that we always underfund, we always overlook. We kind of celebrate the success of the milestone of the development of the technology, and it should be celebrated. It's a massive success, but there's so much that needs to happen after that we don't value and we don't prioritize. And it's a lot of the legwork of actually bringing programs to people who need them most. So I would love to see more focus on that going forward.
I'd have to go with the data transparency option myself. And again, I think for a host of reasons, many of which are unjustifiable, we have not done the kind of drill down, subgeographic drill down of data that we can and should be doing across the country. I've been seeking a data set from our state Office of State Health-Wide Planning and Development now for a couple years that would enable us to do the kind of drill down to identify geographically where there are concentrations of preventable ED and inpatient utilization, and similarly do the overlays of COVID spread in those communities. Because once you begin to look at this, and we've been doing convenings of leaders where we could get these data, it's compelling. It provides any justification that anybody would need to better align and focus our assets. So that's where I would go first. I have a question for Nicole and Jennifer as it relates to the workforce side of the equation. There's a lot of discussion about community health workers and promotores as playing the key role in doing testing and contact tracing and dissemination of the vaccine. Some have said, well, that doesn't really deploy the full spectrum of their expertise, which I would agree with. But at the same time, they bring an understanding, lived experience in these communities that is difficult to match with other aspects of the workforce. And the healthcare community is increasingly recognizing that they, going forward, are an important part of the larger health workforce. Is that something do you see problems with that perspective, or are there alternatives that make more sense to you?
I think we would be much better off if we had that kind of workforce to both extend the work of contact tracing, to have a connection to the community that they're intervening in. I mean, I think that's a really critical aspect of it that community health workers often do. And I think this effort to suddenly scale up contact tracing teams, which involves, contractors getting big government contracts and then hiring people who may have a connection to the community, but may not. Ideally, this would be a sustained workforce that we could use for other things during peacetime. There's any number of public health problems that could be tackled. Opioids is one issue, many other things that they could be working on, but then tapped for an emergency. I mean, when we have seen health departments do contact tracing when they've really needed to in an outbreak, because their workforce has been scaled back so much. I mean, they often tap, disease investigation specialists from the sexually transmitted infections unit, TB nurses. So they tap these other workforces. But if we had, a dedicated kind of community-connected workforce, I think it would be really helpful and then potentially useful in vaccination. I did a study about a year ago looking at how ready state and local health departments, actually with local health departments, were to do mass vaccination. The idea being, like, if there were a pandemic and you needed to vaccinate a lot of people all at once, could you? And the answer was they basically weren't ready. And a real limiting step was workforce. Now, vaccines are tough because you need people who are qualified to administer vaccines, but it doesn't mean that they couldn't be trained and they couldn't have, credential changes to allow this in a public health emergency, but that requires planning in advance. So I hope we go forward learning these lessons and plan better for the next time, because I think everybody is, fairly convinced that this is probably not the last challenge we'll face.
Yeah, and I would agree with that entirely. I think that's a great summary. The community health worker workforce and working within communities is something I think that is really undervalued in the U.S. I started off my career as an outbreak investigator at the Florida Department of Health, and we were doing outbreak investigations and contact tracing in rural communities. And if we didn't have links with those communities, we would have never gained access. We would have never gotten the information that we needed when we're trying to talk to people about somewhat sensitive information that they need to provide in order to help public health, and so that we can help them make the best decisions going forward. And I think that workforce has shrunk even significantly more in the time since. And that's put the U.S. at a very great disadvantage in terms of dealing with this pandemic. Yeah. So I hope that's something that will be invested in going forward and recognized as valuable and critical contributions to pandemic preparedness and control.
Great. Thank you.
Yeah. Well, thank you so much, everybody. I felt like I learned a ton. I stopped tweeting because I had to listen too hard. But I also got the hashtag wrong. It is AHCJ Summit moving forward. So I'll keep moving on. And also, as far as the breakout rooms go, the links to the breakout rooms are going to be posted after this session. And all of my wonderful panelists will continue to answer questions. Thank you so much. I learned so much. It's wonderful. Thanks a lot for your time.
Thank you, Amy. Thanks for having us.
Bye.
Bye-bye.